We can hear you.
Yes, you can go ahead.
Okay, thank you. Namaste and a very good evening to everyone. On behalf of Mountain Medicine Society of Nepal, I warmly welcome you all to today's session of our webinar series Himali Sambad Insights in Mountain Medicine, a platform dedicated to sharing knowledge, experience, and advance in mountain, wilderness, and high altitude medicine. I am Asika Aryal, member of Mountain Medicine Society of Nepal, and I will be your moderator for today's session. Through Himali Sambad, we aim to create meaningful discussion between expert, professionals, students, and mountain enthusiasts from Nepal and around the world. In a country like Nepal, so closely connected with the Himalaya, we believe that promoting awareness and education in mountain medicine is both relevant and essential. We are truly delighted to have all of you with us this evening for another exciting and insightful session. It is my great pleasure to introduce our distinguished speaker for today, Dr. Steven Roy. Dr. Roy is an adjunct professor in the Department of Emergency Medicine at McGill University, adjunct assistant professor at University of Calgary. He also served as the co-program director for the resident physician elective in wilderness medicine. Dr. Roy is international respected for his extensive expertise in wilderness expedition and mountain medicine. His remarkable qualification reflects his dedication and excellence in this specialty. He holds various degrees, Doctor of Medicine and Master of Surgery, Diploma in Mountain Medicine, Diploma in Mountain Emergency Medicine, Diploma in Wilderness and Expedition Medicine, Fellow of the Academy of Wilderness Medicine. His contribution to mountain and wilderness medicine are inspiring for us. Having an expert of his caliber with us today is truly a special opportunity. Today, Dr. Roy will be sharing his valuable insight on the topic Physiological Approach to Altitude Illness. Please join me in warmly welcoming and expressing our sincere appreciation to Dr. Steven Roy for taking the time to be with us today.
Thank you so much, Ashika. Namaste. Good morning from Mountain Standard Time here in Canada. It's really a pleasure to be with you, and thank you for the opportunity. I'm going to share my screen, and then once I confirm that you guys can see it, then we can get started. There we go. You're all able to see the screen?
Yes, sir.
All right, excellent. Well, if it's all right with you, I'll get started.
Before we begin this session, I would kindly request all participants to actively engage, and if you have any queries, we'll be discussing at last. I encourage everyone to remain attentive, and without further delay, invite him to I will invite Doctor to begin today's session, sir. The floor is yours.
Awesome. Thank you, Ashika. All right, so today we're going to be talking about a physiologic approach to altitude illness. These are my disclosures. I receive money for research, but I have no conflicts of interest. And I have two companies, one that teaches wilderness medicine and does consulting and expedition medicine work, and then another company that does medical device research and development. So I just want to set the stage for the talk. A couple things. One is, of course, I would love it to be interactive. So if you have questions, please feel free to drop your questions in the comments, or we'll have lots of time at the end, hopefully, for questions as well. And Ashika, you can let me know if there are important questions that you want to stop for, or if we address them at the end. The other thing that I'd like to do is I'd like to sort of share the way that I think about this talk. When I learn about a disease, I like to build a mental model I like to have a way of thinking about the disease that allows me to understand some of the important features of the disease. And ideally, that model is accurate. But what matters less is whether the model is correct or whether it's valid. And what matters more is whether the predictions that are made based on the model are useful. So I think the management of the most common and the two life-threatening altitude illnesses can be remembered and essentially derived from only a few principles of basic physiology. And I think these principles lead us to make useful conclusions about the treatment of these illnesses. So with this in mind, I'm not going to talk about epidemiology. I'm not going to talk about guidelines, even though the treatments I'll discuss are the guideline recommendations. I'm just going to share with you sort of the principal internal model I use when I think about altitude illness. And hopefully this will be a new perspective that complements what you've already learned and already know and already experienced about altitude illnesses. By the end of the talk, you should understand how organs in the chest, the abdomen, the head, and the neck determine an individual's ability to adapt to a change in altitude. And by extension, you should understand how to treat the problems that can result at altitude. So here's a quick overview, bird's eye view of what we're going to discuss. Namely, we're going to discuss as concisely as possible what we mean by thin air, what peripheral ventilatory control and hypoxic pulmonary vasoconstriction are. I'm going to use a lot of medical terms in this presentation. Hopefully that's okay. If there's something that you don't understand, please stop me so I can make sure it's clear. And then we're going to use these 4 principles to intermixed with the discussion about the most common altitude illness, acute mountain sickness, as well as the 2 life-threatening problems, high altitude pulmonary edema and high altitude cerebral edema. So let's go. So I'm going to start from the very beginning. We're going to talk about hypobaric hypoxia, which means low pressure, low oxygen. So low oxygen resulting from low atmospheric pressure. And we're going to start right off the top with the first take home, which is that altitude illnesses all arise from the same general cause, which is hypobaric hypoxia. And so let's quickly make sure we understand what hypobaric hypoxia is. So if we were to take a column of air that starts at sea level and goes all the way to outer space, we would get this column. If it was 1 centimeter in diameter, this column of air will weigh at sea level 1 kilogram, and it sits and pushes with the weight of all the air in this column on your body, and is what keeps us at sea level pressure. And in this air, we have 20.95% oxygen. So here I've shown a box, and in the box there's a volume of air. Excuse me, my voice this morning. And in the box there's a volume of air, and approximately 21% of that air is oxygen, represented by the red dots. And when we go to higher altitude, the weight of the column of air above us gets smaller, and that's why the air gets thinner. And so here you can see the same box with more space between the air molecules, but still the same proportion of oxygen to nitrogen and other components. So we have still the same percent oxygen, but we have fewer physical oxygen molecules because the molecules are farther apart. And this is called, and this is what we mean by hypobaric hypoxia. So I know this is a little bit boring information that you're probably already familiar with, but I want to go back to something you may have learned in medical school or in physiology and reinterpret it a little bit. So this is a an unwieldy formula called the alveolar gas equation. Some of you probably have PTSD just seeing it on the screen. But I think really importantly, the complicated parts of this formula can be simplified really easily. And we can basically take this whole thing on the right and say, and simplify it to just say basically PCO2. And then what it tells us is that the concentration of oxygen in the alveoli, in the lung, at any altitude depends on mostly on the fraction of inspired oxygen, which if you're not breathing supplemental oxygen is just 21%, and the atmospheric pressure. And knowing that, and maybe a little bit on CO2, but knowing that at any altitude, the oxygen pressure in the lung depends mainly on two variables, we can then see how, when we have a drop in atmospheric pressure, how we can fix it. So we're going to simplify this a little bit, but atmospheric pressure at sea level is about 760 millimeters of mercury. And the portion of air that is oxygen is 20.95%. That means that the pressure of oxygen at sea level in the ambient air is about 160 millimeters of mercury. And if we go up higher, let's say we go to roughly 7,000 meters. This is me when I was 18, climbing in the Andes. We're about just below 7,000 meters here, and atmospheric pressure is about 308 millimeters of mercury. And so at this altitude, we can calculate that the partial pressure of oxygen in the environment is about 65 millimeters of mercury. So we've had, nearly a half, or a little bit less than half, of the pressure of oxygen that we had before. And so the question is, if we're experiencing 40% of the partial pressure we experience at sea level, how do we fix it? And so there are sort of two ways that we do that. So, and I'm illustrating those here. The first way is that we compress the air more, and that is done either through descent or with a portable hyperbaric chamber. The other way is that we can increase the number of the red dots, or the oxygen, and by adding more oxygen, we increase the partial pressure of oxygen. And so descent, simulated descent with the hyperbaric chamber, and supplemental oxygen all decrease the hypobaric hypoxia, and therefore would all of these methods will improve altitude illnesses. And these can effectively be equivalent. There's no difference physiologically in terms of the hypoxia part that we can determine based on whether we're using just a lot of oxygen and normal baric normoxia or hypobaric normoxia, or whether we're using normal baric hypoxia or normoxia. My apologies. So now that we've defined hypobaric hypoxia, before we get into the physiology stuff, I just quickly want to define high altitude. People have defined this differently in lots of different places, but generally, high altitude is usually defined as starting around 1,500 meters above sea level, which is where the physiologic stress of hypobaric hypoxia starts to be observed. It's very uncommon to get altitude illnesses at these altitudes, which is why most aircraft are pressurized well within this range. But it's definitely possible to get altitude illness at 2,000 meters, even though this is pretty mild altitude. It's after rapid ascent from sea level with someone particularly with comorbidities, that is possible. At very high altitude, AMS, acute mountain sickness, becomes quite common, and that starts to be more apparent around 3,500 meters. And finally, again, there's different thresholds, but for extreme altitude, I've used the altitude we used in the altitude illness chapter of Mountain Emergency Medicine, and we used 5,800 meters because it's the typical altitude on a mountain in the Himalayas or the Andes. where barometric pressure falls to half of the pressure at sea level. So we can say at that point, we are at extreme altitude. So this is just for so that we have a common vocabulary about what we're talking about when we're talking about high altitude. But we'll move on into the physiology stuff here if there are no questions about hypobaric hypoxia and high altitude definitions. Okay. So this is the first physiology that I'm going to explain, and I think it's a critical piece to understanding altitude illness. It is normally very complicated, but I'm going to explain it in just 3 slides because it's also can be thought of in a relatively simple way. So let's try to do that. So ventilatory control or your breathing is tightly controlled by two different parts of the body. One is the central chemoreceptors in the ventrolateral medulla, which are very sensitive to pH. This is what we were taught in when I was in med school. We really glossed over the second component, and we really said the most important part of breathing control is CO2 in the blood. And this is true, but it is the CO2. It's really the pH of the CSF, which correlates with the pH of the blood, which correlates with CO2 in the blood. So people breathe quickly, they blow off CO2. That makes the blood more alkalemic. When the blood becomes more basic, then the CSF becomes more basic, and these chemical receptors in the base of the brain determine that you are breathing too fast, and therefore tell you that you don't need to be breathing as fast. And this is how the main mechanism that we control breathing. But there's also these receptors in our neck, in the carotid body, that are sensitive to low oxygen, and these end up being really important for altitude illness. So even though that for all intents and purposes, the only source of ventilatory control at low altitudes is the brainstem, at high altitude we end up seeing something that's very interesting with these carotid bodies that are sensitive to low oxygen, and sort of how there's an interesting story is sort of the sequence of what happens when you just go to high altitude. So when you get to high altitude after being at a low altitude for an extended period of time, what happens is the high altitude produces hypobaric hypoxia. Your lungs are getting less oxygen into your blood, and in your neck, these sensors for low oxygen tell your brain, hey, you should breathe faster. So this is called the hypoxic ventilatory response. But when this happens even a little bit, your breathing rate increases just a little bit. What happens is that this causes a decrease in the dissolved carbon dioxide in the blood, and this even slight decrease in CO2, because the CO2 sensors are so sensitive in the brain. This slight change in CO2 causes a slight change in pH, and the slight change in pH decreases the drive to breathe. And we don't end up having this an adequately increased breathing rate for the low oxygen because of the effects of pH of breathing faster. So in other words, in the setting of acute exposure, this is important, acute exposure to hypobaric hypoxia, the initial hypoxic ventilatory response is what we would say is submaximal. It's less than it should be, or less than would be beneficial. So this is the second takeaway. If you're thinking about altitude illness in terms of physiology, after an ascent to high altitude, the hypoxic ventilatory response is initially limited by central ventilatory control. Now, this would be the end of a pretty unexciting story, and enter the hero of the story, the kidney. And I know what you're thinking. The kidney is quite rarely the hero of the story. If you're practicing medicine or learning medicine, like the kidneys are often the problem. But here they're the hero. So if you were rooting for the kidneys, you're in luck. And that was my mandatory dad joke for the day. So, all right. So we're going to talk about renal responses to altitude and how the kidney sort of digs us out of the problem of not being able to breathe faster. And technically, it's not a renal response to altitude. I think it's probably more likely renal response to respiratory alkalosis and or hypoxia. But we'll leave that detail aside or with this little asterisk. So when you breathe fast and you have respiratory alkalosis, the body does not like to move away. It likes homeostasis. It doesn't like deviations from normal. And so when you breathe fast and you have even slight increase in pH, the body says, nope, let's fix this. And the way that we fix this is we tell the kidneys to pee out more bicarbonate. You'll know from internal medicine rotations, we call this compensatory metabolic acidosis. So we have a primary respiratory alkalosis, and we have a compensatory metabolic acidosis. So by peeing out base, we reacidify the blood. And what happens is that relieves the pressure, that relieves the limitation of breathing faster on the brain and allows the brain to permit breathing faster that is still being triggered by these receptors in the neck. So as the kidney brings the serum pH back down, we can have a better hypoxic ventilatory response, which actually addresses the low oxygen by maintaining higher oxygen concentration in the lung as it's being moved out. Breathing a bit faster, a bit higher volume allows that to be a bit more stable, and then getting rid of a bit of CO2 also means that there's more space for the oxygen pressure. So the way this works is after about 24 to 48 hours after a relative ascent to high altitude, you can actually have a reasonable hypoxic ventilatory response at most terrestrial altitudes, and you'll start to feel a lot better, feel pretty good. And this is really critical. This bicarbonate diuresis is probably the primary mechanism by which you acclimatize when you're trekking or mountaineering for any period of time less than multiple weeks. There's, as I mentioned at the beginning, this is a simplification, and there are lots of other things that are going on. But for the purposes of this discussion, we'll assume that the main method of acute climatization is bicarbonate diuresis. So initial acclimatization, this is the next take home. Initial acclimatization depends on renal bicarbonate diuresis, allowing maximal hypoxic ventilatory response. So far we've talked about a couple of physiologic principles. I've shared 3 take-home messages, and I've made one dad joke about the kidney. And this leaves one physiologic principle that we'll need to address before the end of the session. But before we do that, I think we have the main principles we need to talk about acute mountain sickness and start talking about the other altitude illnesses. So let's start with acute mountain sickness. So you already probably know what AMS is, and but I want you to try to think about it with the few physiologic principles that I just described, and let's first frame what it is. So AMS looks like is a syndrome that looks like a hangover, right? It's a syndrome that occurs after ascent to high altitude, usually after a few hours of ascent, and before you acclimatize in 1 to 2 days if you're staying there. And it looks like a hangover. The symptoms include a headache, gastrointestinal upset like poor appetite, nausea, mild vomiting, fatigue, generalized weakness, dizziness, or lightheadedness. There is also poor sleep as part of this, clearly part of the syndrome. Whether or not it's part of the research definition of altitude illness is a different question, but I think generally we can include poor sleep in here. And so these are the symptoms, but to me, acute mountain sickness actually has a meaning, and its meaning is that you're not adequately acclimatized to the altitude that you're at. And so I try to teach people to listen to their body, and the meaning of altitude illness is it's your body's way of telling you not to go up. So when you are reading in a car and your inner ear is telling you that you're moving and your eyes are telling you you're not moving, you get motion sickness. And the way to stop motion sickness is to stop reading in the car, to stop doing what you're doing. When the brain gets information that it doesn't like, it for some reason its instinct is to tell you to be nauseous. And so here you're going up and your body's telling you to that you should be nauseous, then you should stop doing that thing. So the way that I interpret acute mountain sickness is that AMS means that the individual is insufficiently acclimatized to the altitude they're at. And so obviously the solution is not to go higher. So AMS is a hangover. It's like a hangover. It's a nuisance, but it's not life-threatening. It's a sign. And so I think of AMS as uncomfortable hypobaric hypoxia, not life-threatening hypobaric hypoxia. And so what we do is we treat uncomfortable hypobaric hypoxia. So it's really easy. We just let our kidneys catch up. It takes 24 to 48 hours for the kidneys to compensate. You can treat hangovers symptomatically. And then if your kidneys are holding you down, you either wait for your kidneys to catch up or you whip them into shape with a carbonic anhydrase inhibitor, namely acetazolamide. This is basically just a medication that forces the kidney to pee out more base, more bicarbonates. We call this bicarbonate diuresis. And by forcing it to do that faster, this allows us to get to a useful hypoxic ventilatory response sooner. And it can also produce a metabolic acidemia, which means that it's not just relieving the hypoxic ventilatory response from a submaximal response, but it also actually causes a respiratory acidosis. So as acetazolamide, some people will focus on, the reason why acetazolamide is helpful is that it causes a metabolic acidemia a metabolic alkalemia, and then you get a compensatory respiratory acidosis. And I argue this isn't quite the point. It's close to correct, and it probably does happen, but the more important one is that HVR is now not limited by the normal physiology or sequence of physiology. But either way, hypoxic ventilatory response is now maximized together with a bit of hypocapnia, and this allows improved alveolar oxygen. Your alternative is then, of course, to either use oxygen or to descend if it's not getting better. Technically, in the guidelines, dexamethasone is also a treatment. I personally reserve dexamethasone for treatment of HACE. The worst thing we would want to do is to take a medication in face of significant symptoms and continue ascent and then get sicker and already be on the drug that's a treatment for high altitude, for some more severe altitude illness. I don't have the slides this time, but I've done some preliminary work looking at the, how good is acetazolamide at preventing altitude illness, and it's good, but when you compare it to descent or staying at an altitude, it's not nearly as good as those things. So it is better and it will help, but using a drug doesn't prevent us from having a severe altitude illness entirely. It just reduces that risk by in the order of 15-20%. So it's not 100% eliminated risk. So again, this is sort of how I manage it, and ascent is contraindicated when we have signs telling our body that we are not acclimatized. Prevention is gradual ascent. Gradual ascent means that it takes 2 days to arrive to around 2,500 or 3,000 meters, and after that, we change our sleeping altitude by less than 500 meters per day, with an extra day every 1,000 meters. But other guidelines are written differently. They'll say no more than 300 meters of sleeping elevation change a day, but those are the same thing. 300 meters for 3 days, or 500 meters over 2 days, and then a break for 1 day is still between 900 and 1,000 meters every 3 days. So point being, we take it nice and slow on average. The climber's mantra is climb high, sleep low. So we stress our body during the day, and then when it's most susceptible to changes in breathing, we sleep a little bit lower so that our body can adjust. And then we can of course use acetazolamide to prevent it. We use a lower dose for prevention. I was told in medical school that acetazolamide is a weak diuretic, and if you've ever taken 250 milligrams of acetazolamide, I can say that the nephrologist teaching us had not taken this quote unquote weak diuretic. Sometimes the side effects of the acetazolamide can be quite distracting, and so generally I would rather just enjoy the scenery and go slower. But if there's a rapid ascent is necessary, or for other reasons it's high risk, then acetazolamide is an option. For those who are really high risk, you might consider dexamethasone, but again, I would like to avoid adrenal insufficiency, which is a life-threatening problem that can result from people taking dexamethasone for an extended period of time. So I don't usually suggest that for prophylaxis. All right, so we talked about acute mountain sickness, and now we're going to talk about HACE, high altitude cerebral edema. It's thought to be on a spectrum with AMS being mild and HACE being severe. It's unclear to me that is accurate, but at least it's a useful way to think about it. So for the sake of discussion, we'll call HACE a severe, life-threatening type of AMS. Unlike the hangover symptoms of AMS, HACE, the patient appears to be still drunk. In a patient who has altered neurological status, especially ataxia, severe lassitude, altered mental status, encephalopathy, we think of high altitude cerebral edema. It's not really, or the exact pathophysiology of the blood barrier breakdown is debated, and there are these competing theories: the tight brain hypothesis, the venous outflow limitation. There's people have different ideas, but regardless of the mechanism you believe, eventually hypoxia results in the end point of breakdown of the blood-brain barrier, and this is highly inflammatory, which in turn causes swelling if it's not also caused by the other mechanisms, and this results in a positive feedback loop with worsening edema and brain dysfunction. HACE is distinguished from AMS by the presence of neurological alterations like ataxia or trouble walking or altered consciousness, someone who is appears to be in a coma or can appear to be dead even. Dr. Buddha Bosniak has some great local story of some boys in the Himalayas where they think their friend has died and they carry his body down to bury him and he wakes up. And this is a description of high altitude cerebral edema being treated with descent. So the takeaway for how very simplified way I think about high altitude cerebral edema is that it represents breakdown of the blood-brain barrier, or it causes breakdown of the blood-brain barrier. And so what do? We treat life-threatening blood-brain barrier breakdown caused by hypobaric hypoxia. So I think of what are the treatments that I would use to treat a life-threatening blood-brain barrier breakdown caused by hypobaric hypoxia. Well, definitive treatment again is descent. We use dexamethasone by any route we can give it. If a patient has focal neurological findings, ataxia, confusion, then I'm going to give them dexamethasone. I want to descend them, but often these patients are going to be tricky to descend, and it can be very dangerous on a glacier or in another, technical environment to try to carry someone, particularly someone who might be combative or confused. So in some cases, rather than have the person descend alone, or under their own power if they're unable to, if they're having trouble walking, then we can use dexamethasone, supplemental oxygen, and maybe even portable hyperbaric therapy to improve symptoms enough to allow them to descend on their own with some help. Important here to note that a large portion, probably close to half of people with high altitude cerebral edema also have concomitant high altitude pulmonary edema. In my mind, this is causative. It's going to be much more common that people get high altitude pulmonary edema first, and that makes their oxygen saturation even lower, and that even lower oxygen saturation results in high altitude cerebral edema. So these things can co-occur, so they're not mutually exclusive. So I want to move on to high altitude pulmonary edema, but first I want to talk about the last physiological principle that I think we need to understand high altitude pulmonary edema and its treatments. So hypoxic pulmonary vasoconstriction is a process whereby blood flow is restricted to lung units that are poorly oxygenated. This contributes to what's called a ventilation perfusion mismatch and prevents or matching in this case, and normally prevents significant hypoxemia in the regional lung problem. But at high altitude, the hypoxic pulmonary vasoconstriction is no longer very adaptive because the hypoxia is not diffuse, is diffuse. It's over the whole lung. It's not just regional lung problem. And for this reason, unacclimatized individuals all have a degree of pulmonary hypertension. And when this is really severe, this leads to high altitude pulmonary edema. So I'm just going to show you this. It's probably easier to explain looking at an image than it is with just the text. So this is a schematic of these tiny sacs that are the workhorse of the lung. There's thousands upon thousands of these, millions in your lung, and you have these tiny alveoli. You get air into them, and then the oxygen diffuses across the membrane into the blood, and the CO2 diffuses back across into for you to breathe out. The blood comes from the venous blood comes from all the organs that have sent their blood that have low oxygen back to the heart, which pumps it to the lung. As it goes through the lung, the oxygen is replaced on the hemoglobin and in the blood, and then is pumped back to the body. So what happens is your body is designed so that little things don't cause you to die. So, we can adapt to imperfect situations. This is the hallmark of a living being. So when you have an alveoli, for example, that's full of pus here, and this would be, for example, because of a pneumonia. Now, normally it's not two adjacent alveoli. Probably more often it's all the alveoli in one area and none of the alveoli in another area. But for the schematic to work, I had to put them next to each other. So here we have an alveoli that's full of pus. And for that reason, it's not able to get enough oxygen into it, whether because it's collapsed, not pictured, or whether because it's so full that there's really no space for oxygen. And for that reason, the oxygen that normally would be diffused into the blood isn't able to get into the lung unit to get into that. And that means that the blood that passes nearby is going to be less oxygenated than we would like. And this would result in low oxygen in the blood in your body. You would see a low SpO2. But this doesn't happen in many healthy patients who have pneumonia. And that's because you get this vasoconstriction. This blood vessel constricts to send less blood through it, since it's not able to pick up enough oxygen because of the local disease. And that pushes more of the blood to go through the other routes that do have good oxygen. And the effect of this is that you can have a pneumonia. So this is an X-ray of a patient with an upper lobe pneumonia, and you can see that they have this this one part of the lung that's totally full of pus, and the rest of the lung is full of air and is black. And this patient could be walking around and have pretty good oxygen saturations, because that's what this physiologic mechanism is for. It's to protect us from this so that we don't die when this happens. The problem at high altitude is it's not just a small part of the lung. It's not a regional problem. You have hypoxia in all of the lung units because it's the air we're breathing now that is the problem, having low pressure of oxygen, few oxygen molecules. And since it's the whole lung vasoconstricts. And if the whole lung vasoconstricts and I'm exercising really hard and the heart is pumping with high pressure against that resistance, then we get this problem, which is we start to have leakage of blood and water around the blood vessels, around the alveoli. And the problem is that as this worsens, this will worsen oxygenation. And then when you have worsened oxygenation, you'll have even more vasoconstriction, and you'll have more vasoconstriction maybe in the areas with the lots of leakage. And then it's this positive feedback loop where it gets worse and worse because it's everywhere. And essentially there are no units to send this blood that aren't hypoxic. So instead of redirecting blood, you just get higher and higher pulmonary pressure or pulmonary hypertension. And when it's severe, you get this bilateral basilar predominant pattern of puffy patchy density that we call high altitude pulmonary edema. So the takeaway here I want you to think is like high altitude pulmonary edema is primarily caused by diffuse hypoxic pulmonary vasoconstriction. There is complexity to this, but if you oversimplify it for the sake of thinking about the problem that it's caused by this diffuse hypoxic pulmonary vasoconstriction, it will allow you to remember the treatments that we use, which target this mechanism specifically. So let's talk about it. High altitude pulmonary edema. HAPE is a acute, potentially life-threatening respiratory condition triggered by recent descent to altitude. It's characterized by what we call non-cardiogenic, so not heart failure, accumulation of extracellular fluid in the lungs due to leaky pulmonary vasculature. The impaired ventilation due to the presence of all this fluid causes dyspnea on exertion, increased recovery time, and progression to resting tachypnea or dyspnea. So resting tachypnea means breathing fast at rest, not just breathing fast during exercise, and feeling short of breath or dyspnea. You'll notice what I didn't mention here, and that's hemoptysis. So hemoptysis means coughing up blood. This, of course, can happen with altitude pulmonary edema and is definitely a very worrisome symptom. But for those of you who are in medicine or spend a lot of time in an emergency room, I want you to think of the last 10 patients you managed with cardiogenic pulmonary edema, so heart failure causing pulmonary edema, and how many of those patients had hemoptysis. And I'm going to guess that the number is either 1 or more likely 0. Hemoptysis is usually present when it's really severe, and it's quite a late finding. And in general, I think of the same thing for altitude pulmonary edema. If I see hemoptysis, that's because I missed it a lot earlier. So I don't usually list it as a symptom, not because it's not a symptom, but because I think we should focus on these other symptoms, diagnose it early, treat it early, and not wait for people to be coughing up blood to diagnose them with the problem. Finally, it would, if you are ultrasound enthusiasts, I don't know how much you guys use ultrasound in the emergency room or in the ICU. We use it a lot increasingly. So it's super helpful. But here, studies have shown that basically every patient, any person at high altitude can have B lines without, and most of them without ever developing pulmonary edema. So it's a little bit harder to use ultrasound in these patients because it doesn't tell us that this patient has pulmonary edema. It tells us that they have V lines, and it doesn't really, it's not very practical to undress the patient so that I can scan their lungs in the cold when it rarely adds to my diagnosis. So I certainly use ultrasound, and in these patients, if we're stuck and because of weather we're not able to descend, I would probably use wilderness ultrasound, but I would use it a much different way. I would use this to focus on, does this patient have new cardiac wall motion abnormalities, which might point to a myocardial infarction and a cardiogenic cause of pulmonary edema, and actually makes high altitude pulmonary edema less likely if they have some really abnormal cardiac function. So I use it to work through my differential a little bit, not necessarily using it to confirm that something is HAPE, but to explore or disprove that it's HAPE if I think there's something else that might be happening. All that to say, though, if the saturation is low and the patient has dyspnea, we're going to treat hypobaric hypoxia. So when we treat high altitude pulmonary edema, if I think this patient has HAPE, what I do is I treat excessive hypoxic pulmonary vasoconstriction caused by hypobaric hypoxia. So remembering that that's the underlying problem here, I can infer all of these treatments. So obviously, a life-threatening disease caused by altitude, the treatment is descent, and everything else is really to reduce hypoxemia enough to allow descent safely. So if rest and supplemental oxygen are really, the mainstay. I was told once that when you have a horse race, that the horse at the end of the race can have pulmonary edema from just this massive amount of blood that's being pumped through the muscles of the body, being slammed through the lungs. And so if we lower the heart rate, we lower the cardiac output, we lower how much is going through the lungs, we reduce pulmonary hypertension. And at the same time, we're giving them oxygen to vasodilate those blood vessels and reduce the pressure further. So rest pairs really well with oxygen in these patients. If it's mild HAPE and I have a monitored setting, I can even use these as my primary, as sort of like instead of descent. If it would be unsafe, for instance, I can try doing this first, and that can be effective. I can use hyperbaric therapy, the portable hyperbaric chamber. We can use PEEP or CPAP, expiratory positive pressure, as well, will be helpful. And then we can use nifedipine, which is a pulmonary vasodilator. This is sort of our mainstay. Phosphodiesterase inhibitors are also very effective, sildenafil, tadalafil. And so these medications directly act in opposition to that hypoxic vasoconstriction and undo some of the underlying physiology. Again, if a patient is really sick with high altitude pulmonary edema, the plan is to descend them. And these are all things that can help me make them well enough to be able to walk down slowly on their own, so that I don't have to carry them through difficult, dangerous conditions while I myself am probably a bit hypoxic myself. So prevention, we prevent hypoxic pulmonary vasoconstriction. So we do a gradual ascent. We use acetazolamide. Nifedipine, we use nifedipine more in patients who have had HAPE before, who need to still go to altitude, who don't want, for their jobs, they still want to be going to altitude. We need to be careful. Sometimes, the correct choice may be to change the job if they're having recurrent life-threatening disease. But if they've had HAPE once before and they insist on going back to high altitude, then we can use nifedipine to help us prevent it. So just to summarize, that was the last altitude illness that we had discussed. So we talked about a couple different types of human physiology. We talked about how altitude causes hypobaric hypoxia, talked about central and peripheral ventilatory control, renal response to altitude, hypoxic pulmonary vasoconstriction. We talked about how these produce and how this physiology can be used to treat acute mountain sickness, high altitude pulmonary edema, and high altitude cerebral edema. As I mentioned in the beginning, the process is way more complicated and complex than I conveyed. But I think that this oversimplified physiologic model is a useful way to think about altitude illnesses. So just to round off the take-homes, I think of acute mountain sickness as evidence that someone is individually insufficiently acclimatized to their altitude, and the solution is to become more acclimatized, namely by letting the kidneys catch up. HACE is a life-threatening problem caused by breakdown of that results in breakdown of the blood-brain barrier. HAPE is primarily caused by excessive hypoxic pulmonary vasoconstriction, and our treatments reverse or improve this problem. After ascent to high altitude, the hypoxic ventilatory response is initially limited by central ventilatory control. Initial acclimatization depends on renal bicarbonate diuresis. And so the main mechanism of acclimatization in an unacclimatized individual is peeing out bicarbonate. And if you remember nothing else, the most important thing to remember is all illnesses arise, altitude illnesses arise from the same cause, which is low oxygen from low atmospheric pressure. These are my references, and I would be very happy to take any questions.
Thank you very much, Dr. Roy, for the insightful presentation.